I'm Chuck Moellenberg, the president of the nonprofit corporation, and I will ask, I guess, starting with Dave and going down the line, if you would introduce yourself, tell the audience one thing you'd like them to know about you.
I'm David O'Brien from Toronto, Canada, and I run an organization called Yorktown Family Services, which has one of 5 preventing and engaging with people on the pathway to extremist or hate-based violence. And we engage with people that are all the way at the top level under terrorism investigations right down to prevention work. And one thing that I want you guys to know is that I've been in the field of mental health for 25 years, and I'm just so proud to be here today and taking all those experiences and opportunities and kind of honing in on developing this program in Canada over the last few years. So what a privilege to be here and what a privilege to do this work.
Hi everyone, my name is Rajeev Ramchand. I'm at the RAND Corporation based in the Washington, D.C. office, where there I co-direct a Veterans Policy Research Institute. I'm also an epidemiologist by training, and I guess the one thing I want you to know is that I love science and I love data and I love evidence, and so I push for and advocate for evidence and science and research as much as possible, and the use of that research to inform public policy decisions. But on a more fun note, I love hosting dinner parties, and if you ever come to DC and give me advance notice, I'll have you over.
Hi, my name's Emma Cardeli. Since I already did a formal introduction earlier, I'm just gonna go straight to the fun one, which is, well, 2 things. One, Rajeev throws very good dinner parties, so I definitely encourage you to follow up on that. 2, my spirit animal is a dolphin.
That's going to be hard to top. Good afternoon, everyone. I'm Jim Marley. I'm the interim dean for the School of Social Work at Loyola University Chicago. I'm primarily here because of my involvement with the Prevention Practitioners Network. Been a social worker my entire professional career for 35 plus years. And I guess the one thing to let you all know is I celebrated my birthday yesterday. I was a little bummed when I saw that the dates for next year are going to be in October, because I was sort of hoping to make this conference overlap with my birthday on a regular basis, but no such luck.
Well, next year, Jim, we'll have a cake waiting for you, even though it's a year late. We have a lot of territory to cover in just a half hour. Let me just say at the outset that we are forecasting what Working Group 13 will be doing. Working Group 13 is actually meeting in a breakout session tomorrow afternoon at 3 p.m. So for much more of the details, please go to the breakout session tomorrow afternoon. Let's start, Rajeev, since you love data and evidence-based research. In this field, what does your research show is needed to improve health systems?
Well, I'm going to take a step back and not actually talk about this field. I think that we all know that mental health, and we've heard today, the mental health system will play a role in this ultimate goal of eradicating hate. What I want to do is, from a US perspective, what I spend a lot of my time thinking about is mental health policy. So I do policy research. And oftentimes I think that you can really boil it down to quality and access. And I think my colleagues today are going to talk a lot about quality, especially as it relates to extremist violence and violent behaviors. So I want to just talk about access. And what I want you to go away from is that the United States, access to mental health care services in the United States is extremely problematic. We have huge wait lists. We have a demand for mental health services that far outpaces the supply of services available, which has an impact on the quality efforts that my colleagues are going to talk about, because there may be no incentive to perform high quality care when you have people ringing on your door for appointments. We have an increasing number of providers who are out of network, who only take private pay. COVID has exacerbated this. We have people in our state and local public mental health agencies who are leaving those positions. We have burnout among our providers. And I say this, and not to discourage you, I do think mental health has a role, but we have to think about, when we think about mental health solutions, how is that access going to occur? How are we going to ensure that the people that we refer to mental health care services have that access? And we have to think long term. We can't just think the first appointment. You know, we've spotted somebody, we really recognize that they need help, we're gonna refer them to a mental health service. I think that they'll get crisis services. I think our system is equipped to provide that. Will they get follow-up care that they need? That's when all these things like, well, what insurance do they have? Are there providers in network? Is there a licensed mental health provider in their community within driving distance, a reasonable driving distance? All of these things are gonna impact. And so what I think that we have to be thinking about, and I'm glad that my colleagues are gonna be talking about this partially, is alternative ways of ensuring access. And so this could involve, and we'll talk about later, the use of peer support specialists. This could include alternative payment models. This could include ensuring that our rising mental health workforce is increasingly diverse and that they're trained in some of these quality improvement metrics. It takes all of these approaches. But it also, and I'll end with this, the solution cannot be exclusively a mental health one. That's why everything that people are doing right now, talking about school-based prevention, technology-based prevention, all of those are going to be needed, and we shouldn't disinvest in those. We should, because I don't see this mental health policy system kind of fixing itself within the next 20 to 50 years. I see us still having struggles, so we really have to be thinking about a multi-pronged approach.
Well, my daughter is a social work clinician in Detroit. Her caseload typically was 140 to 150 children, which is astronomical. Mm-hmm. And I know exactly what you're talking about, because she would constantly complain about how she didn't have the time to see all the patients she had, much less take in new patients. Dave, maybe you can tell us from your perspective, what is being done? What kind of work are you seeing to try to make things better?
Yeah, just launching off the point around wait times and wait lists, the people we work with can't wait. They're at risk to themselves and others, and I think we've seen a lot of manifestos with the shootings in the United States, and of course in Canada too, we're not immune, is that people actually showed up to emergency departments. They actually went to mental health centers looking for support and help. So in 2020, an opportunity came along for Yorktown Family Services. We were approached by a local police department and said, hey, you guys might be interested in applying for this type of work. And I was very well versed in sort of counterterrorism and as a hobby. And I went to my executive director and said, we're actually going to build this program that's going to use behavioral health interventions to stop people from committing terrorist acts. And for a typical mental health center, that's a neighborhood center, that was unheard of at the time in Toronto. I'm really proud to say 3 years later, we've helped over 140 people move away from violence. And so that's been a huge experiment, a huge risk our organization took, but it was successful. But the problem we have in Toronto, the problem we have in Canada, across the world, is that our program, our ETA program, estimated time of arrival, works on an island a little bit because we still don't have social workers, youth workers, social service workers wanting to do this work. And so I think when we first did our first job posting in 2020, nobody applied to work for this program. Fast forward to 2023, our last job posting we put out, it was like 50 to 60 resumes came in. So we are making a difference at a local level, but that's not good enough. And we've trained over 3,000 practitioners, healthcare practitioners in behavioral health interventions. But what we need to do is actually integrate our learnings and our training and capacity building within health systems networks. So in Ontario, we have an initiative by the provincial government that has introduced 22 youth wellness hubs across the province of Ontario. So I'm really happy to say over the next few months, we'll be engaging with those 22 sites to create a capacity building knowledge exchange network around behavioral health interventions, helping people to early identify someone at risk and then getting them to the right place at the right time. We also have in Ontario something called the Ontario Health Teams. So each region of Ontario has an Ontario Health team that's responsible for coordination of services. That's another health system that we need to be integrating with, and we will as part of a new funding agreement we have with Public Safety Canada and the Canadian Centre for De-Radicalization. So we're excited to kind of take our learnings, but we can't be working alone. I think you would agree that this is actually a public health issue, maybe even a public health crisis.
Mm-hmm.
Jim, from your perspective in Chicago, I mean, what do you see can be done?
Well, I think to just dovetail on the comments made, I mean, we're really talking about a workforce development piece. Mm-hmm. I think we've heard from various speakers the issues that arise when people are assessed, triaged, perhaps worked with acutely, and then there's the issue of where's the workforce to do the continuing work. Where are the clinicians, the trained clinicians who can really have a handoff from law enforcement or an emergency room and really engage in the longer term work. To that end, obviously, training becomes a critical component of this. An example, I know Emma, you mentioned it earlier today, the Prevention Practitioners Network here in the US and the Canadian Prevention Network are collaborating on developing what we hope will be a series of trainings. Right now, we're working in conjunction with the American Psychological Association, and at least we've kind of conceptualized it as kind of intro 101 training for anybody who's part of the American Psychological Association. But then for those that really want to move into the pathway of taking on these cases, looking at sort of a couple of advanced trainings that would give them more in-depth knowledge about intervention strategies, best practices, research-informed intervention. So, and again, the plan is hopefully through these combined trainings to really begin to look at other professional organizations like the National Association of Social Workers, school counselors, et cetera, because the idea is really to begin to develop the competencies so that individuals who are used to doing direct practice will be able to feel confident and competent to take on these cases. And I think that speaks to, I think, one of the other, I guess I could say, sort of gaps in the service in this arena is we oftentimes talk about assessment, triage, getting people sort of immediate help. What's frequently missing from this approach is really the long-term commitment to the individuals we're trying to help. Mm-hmm. We know that many individuals who have gone down violent pathways, they need education, they need stable housing, they need job training and job support. Very often the violent activities or violent communities they're part of may have interfered with their educational process or their employment. So these are people that have gaps in their resume. And it's one thing to say, you know, I was sick for 6 months. You know, it's another thing to say, you know, how do I explain a gap when I was, you know, kind of flying below the radar in a neo-Nazi group. So those pieces are oftentimes missing, and I think it becomes one of those solutions where many different professions are going to have their hands in effective long-term intervention to keep people from falling back into those old patterns. So the training is one way of beginning to develop the workforce, but even that workforce is going to need to begin to think about how it pulls in different systems at kind of broader levels, and how do you begin to integrate thoughts about housing and education and other kinds of trainings, because those are going to have to come from other organizations where that's really their skill set.
Emma, you've been nodding a lot as everyone is talking. What can you tell us about, from your work, what is being done to help close these gaps?
Yeah, I'm just really appreciating everything my colleagues are saying. Incredibly well said. So to piggyback off of some things that have been noted earlier, from a training perspective, I and my team at Boston Children's Hospital, with the support of the Department of Homeland Security, received funding about 2 years ago at this point to develop the first ever clinically useful risk assessment and management tool for targeted violence specifically. And that tool, called the TSAM, is a tool that's designed to be really client-focused, collaborative in nature, to train mental health professionals on how do we identify kind of these unique, individualized drivers of violence, what's motivating this particular person to think about violence, to want to engage in acts of violence, and then how do we link those assessment results directly to treatment planning accordingly to ensure that mental health professionals actually are creating kind of violence-focused treatment plans specifically. And interestingly, you know, in developing that tool with my colleagues, you know, there's a few things that people have already said that we really tried to kind of hone in on in its development. One, from an access standpoint, if we're really like targeting drivers, those motivators, as the key component to treatment in terms of mental health specific role, treatment can be much more focused and ideally, potentially more short term. We don't necessarily need to be here forever and ever and ever. We can really hone in on those drivers. We can treat those drivers, those problems that are leading to violent radicalization. And it helps, I think, with a workforce that you guys are describing is just so weighted down in so many ways, really hone in on what do I uniquely do, and then how do I collaborate with my colleagues in other sectors to address these other really, really key components that are contributing to somebody's violence potential. So the TSAM has now been developed, which is wonderful, and we've actually trained. This past year, we pulled together a cohort of 45 mental health professionals all across the country who participated in our first TSAM training and learning community. It's been a really awesome experience. It's been actually just exciting for me to see how thrilled mental health professionals actually are to engage in this work, how they kind of want to step up to the plate when given a certain amount of education, which they haven't often gotten, as I mentioned earlier, in graduate school, for example. And what we're seeing is that even just from the training alone, you know, we saw significant increases in practitioner confidence in identifying, assessing, and treating clients at risk for targeted violence. 100% of the clinicians who received the training said the training was helpful. 85% said they intended to incorporate the TSAM into their general clinical practice. And we recruited a generalist group of practitioners for this reason, not just those who are typically used to working with more high-risk clients. 92% of the clinicians said the training helped them understand risk and protective factors for targeted violence, would help them actually create violence-focused treatment plans for their clients. So the data is really promising, and some of the work of our working group tomorrow, too, will be talking about what's next around both the development of the TSAM and next steps there, but also how do we bring together mental health practitioners, we kind of unite around this goal of preventing violence and enhance these kind of broader prevention communities so that we're not working in silos and able to help each other out a bit more in a space where, I mean, collaboration and consultation is critical to getting it right.
Great, I look forward to hearing more about it tomorrow. Rajeev, you mentioned earlier a peer mentor model certification program. Could you tell us about that, please?
Yeah, so Emma said earlier today that we're at the nascent stage, and Yorktown is 2000, so it really is at the beginning, or to 2020, you said. Yeah. So what I think is really exciting is within the mental health field more broadly, the importance of people with lived experience and peer support specialists are becoming increasingly recognized as very useful components of the mental health team. But the mental health system is kind of working backwards to say, how do we incorporate them in? Because not many people know how to incorporate peers into the treatments that they provide. Mm-hmm. Because we're at the new stage, we can actually start building peers and those with lived experience and the role that they will play at the very early stages. And I'm excited that our working group tomorrow, we have Katerina, and this is her specialty, this is what she's been working on, so she's gonna be joining us, and we can bring in the roles of peers and kind of develop, you know, what this ideal system might look like. And I really think it's promising because it also, not only do they offer really unique and valuable peers with lived experience, offer unique and valuable perspective, but we can think of them as taking some of the low acuity burdens off of other licensed or mental health practitioners and kind of do some task sharing, if you will. I'm also kind of excited in the mental health space, I'll say more broadly, on, and I'm with 3 clinicians, so I hope that I don't get, you know, pummeled backstage.
Go for it.
But the role of chatbots and AI, and to what extent digital interventions could actually take away some of the responsibilities.
24-hour service, 2 in the morning, I'm in crisis, at least I get some kind of response.
Yeah.
Absolutely.
It's exciting. We're just at the cusp of this, and I think that it'd be really exciting to see how we can bring in some of these emerging technologies into what we're discussing and the capabilities and the system that we would ideally like to see.
But, yeah, I mean, you just raised a great issue. I mean, we've been reading some about the ability of AI to start making diagnoses now. What's your impression of where that stands? How good is it?
I know that from our data at Yorktown, when our clients are at the edge of either hurting themselves or others, it's usually late at night. Business hours, you know, we're not open 24 hours a day or 7 days a week. I think AI plays a part, particularly in at least something responding at that time of night, overnight, you know, really early in the morning. I would have to shift a little bit, but that has to be followed up with a human response, though. But there is a place for that. We could see that working in our program. Mm-hmm. It's Friday, it's 1 o'clock in the morning. Someone is really revved up. They have no one to call because their workers are sleeping, and this response can kick in. Yeah.
Is there a role for virtual reality in the training that you're thinking about?
I mean, yeah, I mean, in social work training and mental health, behavioral health simulation labs are starting to pop up. We're actually building one at Loyola in a few months. But you're seeing where people can practice on standardized patients in learning different kinds of clinical skills. And you can create scenarios that would involve people showing warning signs, other kinds of issues. Because again, I think many of us in our various avenues that we work in, when we talk about what we're doing or we talk with other clinicians about the work that we're doing, we all have probably had the experience of a clinician saying, I think I might have somebody like that on my caseload already, but I didn't know how to connect the dots. I didn't have a framework for organizing what I was seeing in this way. And so that's part of that work, is just trying to help clinicians who may already be engaged with people in this space, and they just don't realize it.
Mm-hmm. When we opened the program at Yorktown, nobody had even heard of what we were wanting to do with our regular staff team. Right now, we're getting referrals internally from other programs because people are asking the right questions. It's out there, and I think we have to equip everyone to ask those questions, right?
Great. Emma, what else do you foresee the working group focusing on going ahead to get to the deliverables that we like to have coming out of the summit?
Yeah. I guess so one big picture thing is that obviously there's a diversity of disciplines within mental health, you know, even as you see represented here in terms of mental health epidemiologists, social worker, clinical psychologists, et cetera. Diversity of disciplines who show up in very different ways to prevent violence in accordance with that discipline. And I know our working group is really focused on kind of outlining core competencies for mental health professionals within each of those disciplines and thinking through, you know, what is the difference, for example, between how a case manager needs to show up under the mental health umbrella versus a therapist? When you think about a mental health professional who's focused on threat assessment, how is that different from risk assessment, from risk management, et cetera? All of these professionals you can call them all perhaps mental health professionals, but they do very different things. They play very different roles, and we as a field really need to kind of create a blueprint, so to speak, that outlines these kind of core competencies by discipline, by kind of stages of prevention, I guess is what I would say. And the working group is, I think, really excited about taking that on.
That's great. I think we have just enough time, so each of you can have a minute, if you like, for closing advice that you would like to give. Jim, should we start at your end this time?
I know that a lot of organizations, agencies, et cetera, think about training. They want to start training. They want to create some kind of training program. Again, I think reaching out to members of this working group so that you're not sort of recreating the wheel. There are many platforms, many frameworks for different kinds of trainings. So if you just received a DHS grant or something and part of your grant is creating a training, talk to us, talk to this working group. We can point you in the direction of people that are already a few steps ahead of where you might already be and can help you with some lessons learned and problems to avoid.
We're all about not reinventing the wheel, that's for sure. Emma?
Ditto. I don't know what to say on top of that, but I guess, so we are about to launch in partnership with the Prevention Practitioners Network with some additional DHS funding we recently received, a prevention and practice learning community that I really do think is going to be a beautiful way to take some of the incredible things the PPN has already done, but I guess expand upon it by creating a space that really allows clinicians to case conference at a different level, clinically consult with one another across the country. If you are interested in joining that prevention and practice learning community, find me, find Brett Steele, find Neil Saul. We would love to have you be a part of that.
You know, at this conversation, I didn't come up here thinking this, but I have become very excited about the innovation. I know Vidya talked about it, and she runs or is part of the working group earlier today. And I just think that there's a lot of opportunity. I recall last year, the holograms of the Holocaust survivors. That was really innovative to me. This year, I was just listening to the preview for Meflahun's podcast that they have coming out tomorrow, which uses a true crime podcast to promote bystander awareness training to reach a broader audience. And I think that we, as the mental health working group, I've thought in your questions about virtual reality, Chuck, it really made me think we should be pushing the envelope as well. What can we do that's different, that's unique? How can we think about systems? And maybe that's partnering with some of these other groups and thinking about using their strategies so that we can kind of reach out and reach a lot more people a lot more quickly.
Dave, you get the last word.
Last word, okay. I think if you're an organization in the building today or watching this online or on a tape later on, I'm aging myself, I think it's really, this is gratifying work and we're needed. Mental health professionals are needed to really eradicate hate. So if you're an organization that's thinking about doing this work, we're really willing to support that and knowledge exchange and talk about our experiences, because this is an important role that we do play in this space. So thank you.
Well, you all do such important work and good work. Thank you very much for sharing this afternoon. Please join me in thanking our panel.